everybody. Happy Friday. I'd like to call the State Employee Benefits Committee to order. We do have a quorum, so I'd like to go to agenda. Are we going to do a roll call?
Yes, please.
Let's forgot.
Yep, so here in person, we do have Director Maxwell, Joanna Carlson sitting in for Secretary Gordon, Jeff Tashner, Karen Peterson, and Bill Overly. Logged in virtually, I have State Treasurer Davis, Commissioner Navarro, Ashley Tucker, and Controller General Miller. Is there anyone that I missed? If you could just raise your hand or announce yourself.
We did receive notification that Paul Bombach would not be able to attend today due to personal reasons. All right, so I'd like to go to agenda item number 2, which is approval of the May 30th, 2025 SCBC meeting minutes. Hopefully everybody had a chance to review those. Does anybody have any questions or discussion regarding the minutes?
I move for approval of the minutes of May 30th, 2025.
Do I have a second? Second. I have a motion and a second. All those in favor say aye.
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 Those opposed? All right, meeting minutes approved. We got one, I'm sorry,
Standing.
one abstention, the representative from DHR. Great, I think we turn it over to Stephanie to give us the director's report.
Thank you. Good morning, everyone. Starting with RFP updates, following the SCBC's approval at the May 30th SCBC meeting, the SBO has begun contract negotiations with Claims Technology, Inc. for retrospective medical and prescription plan audit services for a contract effective July 1st, 2025. For the life insurance RFP, as noted at the May 30th SCBC meeting, the SBO received 3 vendor bids from MetLife through Prudential Insurance Company of America and Securian, also known as Minnesota Life Insurance Company. As approved by the State Employee Benefits Committee on March 21st, the minimum requirements of the life insurance RFP required bidders to complete all appropriate attachments and forms as identified within the RFP. Page 49 of the RFP stated that attachments 2 through 5, 9 through 16, 18, and 20 were required to be included in the proposal. Pages 47 and 48 define the attachments. Unfortunately, the Prudential did not provide attachment 5, business references, nor attachment 18, State of Delaware terms and conditions governing cloud services and data usage agreement with their bid submission. Willis Towers Watson and the Statewide Benefits Office outreached to the Prudential on numerous occasions requesting this information and informed the Prudential that failure to provide the attachments as required would result in disqualification from consideration. Following additional outreach from our office, the Prudential again would not provide the required information. On June 11th, after consulting with our DAG, the SBO notified the Prudential that they were disqualified from the life insurance procurement pursuant to Title 29, Chapter 69 of Delaware Code and failure to meet the minimum requirements of the RFP. The Proposal Review Committee for the Life Insurance RFP will convene on Wednesday, July 9th, and be provided additional details on this decision and continue throughout the procurement process. Any questions on RFP updates before I move to benefit updates? All right, thank you. On June 3rd, the Statewide Benefits Office was informed by Securian of a billing error identified on the State of Delaware's critical illness plan, specifically on the child coverage component. Securian discovered that the child rates on the State of Delaware's critical illness plan were incorrectly loaded during the supplemental health product implementation in July of 2020. This resulted in employees with child coverage on the critical illness plan being charged an additional 15 cents per month in error since the plan's effective date. For all impacted active members, Securian will issue bill credits on their next premium bills beginning in July, which will continue until the overpayment is offset, at which point their regularly scheduled bill amounts will revert. Impacted non-active members, so any members that may have left the state or terminated coverage, will receive a check in the mail for their calculated refund amount. Securian will be mailing a notification to all impacted members, providing details on this error, as well as anticipated refund dates. For the committee's awareness, the statewide benefits office does have a performance guarantee in place with Securian related to the accuracy of payroll deductions, meaning that as a result of this error, Securian will be paying the state approximately $19,000 as a result of this missed metric. The statewide benefits office has been informed that Internal Medicine of Dover, a PCP practice, will be closing effective August 29th, 2025. Additionally, CNMRI, which is a neurology, sleep medicine, and MRI clinic located in both Dover and Milford, will be closing as of September 19th, 2025.
What was that?
That was CNMRI. It's a neurology, sleep medicine, and MRI clinic.
Do we know whether they're closing or they've been acquired?
They are closing. And that is effective September 19th. The statewide benefits office is working with both Highmark and Aetna to evaluate member impact, communicate these closures to the attributed members, and assist in coordinating care. Lastly, the statewide benefits office has been informed of large-scale closures of Rite Aid retail pharmacies throughout Delaware and in surrounding states as a result of Rite Aid recently filing for bankruptcy. While exact locations and closing days are still being confirmed, closures are expected to take place as early as this week. And actually, there have been a few that have closed in the last day or so. Rite Aid pharmacy patients should be receiving direct communication from their local pharmacy regarding the closing dates as they approach. However, to make sure that our members are not at risk for missing access to their medications, we have communicated this announcement of closures to all of our HR benefit managers, representatives, specialists, school personnel administrators, and participating group representatives to ensure that members are aware and can take action if needed, if they need to move their prescription. Additionally, an announcement has been added to the statewide benefits office news and events webpage, the non-Medicare prescription plan webpage, and Medicare prescription plan webpage to ensure broader awareness of the closures. State of Delaware members who need assistance in finding an in-network pharmacy are able to visit the pharmacy locator search tool that we have through CVS Caremark, or are able to contact CVS Caremark customer service directly for assistance in finding a pharmacy. Those are all the updates that I have today. Are there any questions from committee members? Great, thank you.
I'd just like to recognize Senator Siegfried. Thank you for being here. All right, so moving on to agenda item number 4, which is primary reason for us meeting today, is discussion of the pharmacy benefit manager RFP. I know there have been several documents that have been circulated to committee members, and I believe we're going to start with kind of the Senate joint resolution as to what boxes we checked as far as the RFP, or are we starting with?
So Willis Towers Watson, Brian Holleran will be presenting the minimum bid requirements,
Okay.
walking through each requirement individually, allowing opportunity for discussion and questions. And then following that, we will move to the Senate joint resolution comparison. I think it'll be helpful in the fact that many of the components of the comparison are linked directly to some of the minimum bid requirements. So having that conversation initially will likely help with the Senate joint resolution discussion.
And I also want to add, I believe we've received some information regarding the assistance we received from the Department of Insurance regarding their review of the RFP as well.
Correct, yes, that has been distributed to committee members.
Okay,
That was excellent. I like.
great. Excellent. I'm sure we'll have more discussion about some of the items that are included in that. So if nobody has hesitation, I would just turn it over to Brian to kind of walk us through the minimum requirements.
Sure.
All right, Brian.
Okay. I just have the current
Hold
version
on one
of.
second, Brian.
Oh,
As we go
okay.
through, as we go through this, if we have specific questions, can we?
Yeah, I think that would be most helpful if we
Okay.
paused and took questions as we go.
Okay, thank you.
This is intended to be a working discussion and real-time feedback from committee members for us to hopefully work to finalize some of these requirements.
So we're working on which document?
It was circulated last week. It should be the sections 1 through 4 of the RFP, specifically the minimum bid requirements section.
And
Fair.
this is page 7.
Okay, got it.
Right after the slide there.
Sorry.
Okay, just let me know when you're all ready and I can get started.
And for those in person using a written document, the minimum bid requirements start on page 7.
Brian, I think the floor is yours.
Okay, thank you, appreciate it. As Stephanie mentioned, I'm going to walk through all of the minimum bid requirements with the goal of finalizing these today. Some may not require any conversation at all, and others more so. We touched on a lot of these already and made some updates, so I'll go through each one, and if there are any questions or concerns, please just hop in and we can discuss them. The first 2/3 minimum bid requirements were pretty standard. The first one was just clarification if the vendors are bidding on commercial or EGWIP or both, so very standard there. If there are no questions on that one. The second was around the ability to process prescriptions by the start of the contract date, so July 1st, 2026 for the non-Medicare or commercial population, and January 1st, 2027 for the Medicare Part D EGWIP population. The third one, again, is pretty standard. It's about confirming agreement to accept the data elements in the file feeds from Highmark and Aetna, along with the claims data being sent to DHIN and the state's data warehouse vendor. All three of those pretty standard. The next one here, though, we have, and this was carried over from the last RFP, but it's just around the state of Delaware not giving up any decision-making control over the plan. It is actually a pretty standard one also, but any questions or concerns with those first 4? I think the later ones all require more discussion. Okay, I'll scroll down here. Okay, the next
Hold on 1 second, Brian, we have a question.
Right, I just have, and this may be down the road, but number 4 with the decision-making authority, this is Jeff Thatcher. How does that include establishment of the formulary, or what role does this say the state will play in development of the formulary?
This is more, I would say, about covering different categories of medication. So whether or not you wanted to cover obesity or fertility, but we do address the custom formulary at a later point.
Thank you, appreciate that.
Sure. Okay. This next one was around the state maintaining the ability to carve out specialty dispensing and management to an outside vendor if you decided to take that approach. And there was a question from the last SEBC meeting around if other states are doing this currently, and we did research it and did not find any evidence of other states that are carving out to another vendor at this time.
Sure.
There were some state Medicaid plans that do, but not state employee benefit plans at this point.
Brian,
Karen Peterson.
California has a carve out, as I recall. Or is that maybe-
It's a different arrangement, I believe, and I can get you more details on that. Kristen McKee, not sure if you have knowledge more of California's setup.
Yeah, I know with the Blues plans in California, we're doing a disintermediated plan, but we had seen more from the Medicaid plans and some of the other kind of health plan PBMs going down this approach.
And we would recommend leaving this in here. Things may change, and if you found it advantageous to carve out, that's why we want to leave it in still.
Mr. Chairman.
Bill Overly?
Yeah, I guess I need an example of a real world example. I know I'd raised the issue earlier in the year about GLP-1s and whether we had the latitude to look outside the current contract for cheaper, perhaps cheaper drugs available through compounders. Would this allow us to do that with the carve-out?
Well, the GLP-1s wouldn't be considered to be specialty medications. They are traditional ones at this point. So it wouldn't apply to this min bid requirement right here. But to answer your question about maybe leveraging compounding pharmacies for GLP-1s, that is something that would have to be addressed in the PBM contract. Maybe we could take that back and work some language in around it, but that is not addressed in these min bid requirements here for traditional medications.
And I apologize for my ignorance in terms of what constitutes a specialty drug, but it would seem to me, given the cost of the GLP-1s that we're currently bearing, that it might prove helpful to have that carve-out provision if there are cheaper alternatives available through compounders.
Okay, and we can attempt to work some of that language either into the min bid requirements or the questionnaire, but it's not addressed in the min bid requirements today. But I understand your point about specialty, non-specialty, and although GLP-1s are very expensive and you see the cost of them, they're not typically categorized as specialty medications at this point.
Thank you.
Sure.
Mr. Chairman.
Yep, Karen Peterson.
Karen Peterson. Aren't specialty drugs whatever the PBM says they are? I mean, they decide on the formulary where to place certain drugs, whether they put them on specialty or not, don't they?
Yeah.
I mean, there's no dictionary definition of what a specialty drug is.
There are different PBMs, I would say, define them in different ways. Just because a specialty drug is categorized as such for one PBM doesn't mean it is for another. So you're correct. There's no black and white definition. In general, they're more expensive, more complex medications used to treat diseases that require a large level of oversight. A lot of times they're refrigerated or require special handling when delivered, but there's no black and white definition that all PBMs use.
So they can put whatever drug they want on their specialty list.
They could, yes.
Thank you.
Sure. If they removed a medication from a specialty list or added one, that is something that we would have leverage to push back on, though.
Did we have leverage to push back on the, what did they just take off the GLP? The
Zepbound.
Zepbound.
Yeah, so
We have said no, we can't remove that.
Zepbound, that was a formulary change, non-specialty, where they're excluding it. That is something, and we received that feedback from the last meeting, and that is some language that we're looking to incorporate, where if there is a material change to the formulary, that the state would have the option of opting out of that change.
Okay, but we don't have that ability right now.
Not that I'm aware of, no.
So when I asked the question last meeting, I said, is it because the other drugs are cheaper? And the answer was no, it's because the rebates are better on the other drugs.
That's my understanding.
Mr. Chairman, okay. Yeah, can I, so I think in pharmacy land, I'll call it, I think specialty meds do have a definition, and they can't just throw anything they want in there. I mean, it's items that are high cost, complex condition, specialized handling, like you said about refrigeration, biologic, and so that they meet that kind of definition. First, in order to be called, quote, specialty meds, I mean, you can't throw like an aspirin or something like that. And
no.
PBMs, I don't think they may have a requirement to follow, basic pharmacology definitions. And I think that's what most pharmacists would agree on, is a pharmacy special med as opposed to other meds. So,
Brian, can you comment on that?
Yeah. Typically, PBMs have a different cost threshold that they would consider specialty. When I said that, there's definitely an overall definition that was just given, and completely agree with that. But just that from PBM to PBM, they might not have exactly aligning specialty lists. That's more what I meant.
And I don't want to get into another document, which I don't believe is public, but there's some disagreement about that, which we can cover later.
I'm sorry, I missed that.
No, you can continue.
Oh, continue. Okay. Appreciate it. Okay. The next one here, min bid number 6, is confirming the organization will provide a pricing offer that will separate for commercial and EGWIP populations. So pretty standard there. So the bids that the vendors are giving are going to be separate, commercial and EGWIP, and not relying on each other. And that one is pretty standard. Any questions there, though? Okay, next one here is also pretty standard, just confirming that the organization has reviewed the applicable legislation requirements in attachment 23. So these are around a lot of the state of Delaware federal pharmacy laws. And the next one too is around complying with all state and federal pharmacy legislation, including all CMS mandated requirements from EGWIP.
I think, Brian, just, this is Director Maxwell here, I think there's some, asking for a little bit more specificity around legislation and maybe using something to the effect of laws, regulations, and guidance with regards to that.
Okay, so
as opposed to legislation.
Okay. So updating that language to cover more than just legislation. Okay, we could take a look at that. Okay, the next one, number 9, was pretty standard around third-party agreements. Just confirming that the vendors will agree to enter third-party agreements with Highmark, Aetna, DHIN, and Meritive. Next one, number 10, that we had some conversation around was around the minimum years experience in providing the scope. So this was updated. On a previous version, we were asking for 5 years of experience, and then we changed to a minimum of 3 years experience to kind of open things up as we've been discussing to more of the newer PBMs and smaller PBMs. Any concerns with that threshold number that we changed to from 5 to 3 years? Okay.
So I guess one of the things that last sentence, it says PBM complies with all provisions of Delaware law regarding licenses. Like, is there something as far as being like registered with a particular agency to cover that, as opposed to just saying, complies with provisions? Like, is there some sort of registration or requirement with regards to that to be able to perform this service in the state?
This is Stephanie Hurtis. I can speak to that. So that would be under the Department of Insurance statute and Delaware code. So I think I get what you're saying. We can change, instead of just specifically referencing House Bill 194, reference the specific title for the Department of Insurance to ensure compliance with their regulatory authority.
Yeah, I just don't want it to be too narrowly focused to make sure we're covering everything.
Understood.
And that's important because we have, in our own investigations, found that there's a number of entities operating as a PBM who aren't registered. So I think that's important to have in this documents.
Okay, we can go back and update that.
Hold on, Jeff Tashner.
And this may be more for the insurance commissioner. How lengthy a process is it for someone to become licensed in Delaware? And where my thinking is going, this says that you are licensed. And I'm wondering if, to broaden this, I'm not sure how it would work. I'm just thinking out loud, whether it could be or could become licensed type stuff. And I don't know.
Yeah.
Insurance commissioner, if that's feasible or not, just testing it out.
Well, I mean, there's reasons for the requirements, because you just don't want someone who's brand new coming in without a track record who can't do the job. But to your question, as far as how long does it take? I mean, it's documents that have to be submitted, things like corporate governance and reserves all have to be considered. It can take months, but certainly not years, to approve an application.
Thanks.
So to that point, Commissioner, what if they said they were registered in another state, but not particularly Delaware? I think to Mr. Tashner's question, like, would that be acceptable, knowing that they would have to be eventually get registered, but like, if they're not there now, then they're gonna not be able to meet this minimum requirement, I guess, the concern.
Right. So they would have to be registered / licensed in the state of Delaware to operate in the state of Delaware.
Any other questions on that?
Yeah, just let's, go ahead. No, go ahead.
No, I'm trying to think like it's somebody who hasn't done business in Delaware, but clearly meets all the other requirements and could, this is a barrier. And I understand why. And I think your question is if they are registered and recognized somewhere else, I'm assuming there's no reciprocity, which means they got to go through the Delaware process, which again will probably could eliminate somebody. And I'm just trying to figure out if there's a way we can be more inclusive while maintaining all of the quality measures and assurances that the insurance commissioner is thinking about. So that's why I said I was thinking out loud about it. And I don't know what the solution is, if there is one, but that's kind of the problem that I see with this. And Brian, I don't know if your team can think about that. Because I think what we've tried to clearly do in this RFP is open it up to a broader pool of bidders. And I'm just trying to avoid a barrier here to somebody that, for all of the purposes, could be competitive. But since they've not been here before and not gone through that process, which I would understand, we're now not going to be able to have them be a part of this process.
Would it be possible, sorry, this is Colleen Davis, State Treasurer. Would it be possible for us to put in a clause on this item that states something to the effect of, or currently has an application in for licensing as a PBM in Delaware, or something to that effect? And would that be enough? And again, this is more of a question for Commissioner Navarro. Would that sort of satisfy, at least sort of demonstrating that they have some current standing, a current application in process, something like that?
So, if an agency or entity is licensed in another state and they're in good standing, the process is pretty quick. What I was referring to is a new company wanting to come to the state of Delaware. There are minimal capital and surplus requirements, right? And so, it takes time because you have to do a evaluation of their corporate governance to make sure that they have the appropriate experience and status to be able to start a new company. And so that's why, I'm not, I don't want to minimize the competition, but I also for that the entity applying is capable, because this is a big contract and this is something that has to be right. And so that, if it's an entity registered in another state that's in good standing, then the process goes much quicker.
Mr. Chairman.
Karen Peterson.
Yeah, I'm recalling some time ago that there was a ruling, I don't remember whether it was an attorney general's opinion or a court case, that said that submitting a bid for contract is not considered doing business, and therefore would not require Delaware business license at that point in time. Obviously, if they were awarded the bid, then they would have to become licensed in Delaware. Does that ring any bells with you, Commissioner?
Can you repeat that? I'm having a little bit of difficulty. That's why I'm not on camera.
Yeah, there was a ruling some time ago, and I can't remember if it was an AG's opinion or what, but decided that applying or submitting a bid for a contract is not considered doing business in the state. And that if they were awarded the contract, then at that point, they would have to get the Delaware business license, because then they would be doing business in Delaware. Is there any way you could check that out? I mean, that's back from my old Department of Labor days, that's kind of coming back to me.
Yeah, that's a legal question. It certainly wasn't something that came from the Department of Insurance. But I think they could probably bid, but they can't enter into a contract. So that's something I have to get back an answer from legal.
Thank you, Director Hardis, Statewide Benefits Office. Page 28 of the RFP under licenses and permits does state that prior to receiving an award, a successful vendor shall either furnish the state of Delaware with proof of a Delaware business licensure or authorization obtained through the Delaware Department of Insurance. So a business license is still different, to my understanding, for this specific licensure as a PBM, but we can take this back and discuss whether there is opportunity to revive minimum requirement 10 to something to the effect of confirm your organization is a licensed pharmacy benefit manager or will become licensed by X date. Cautions that we would want to make sure it is prior to the SCBC voting on an award, because the Statewide Benefits Office would not want to begin a contracting process if that has not already been completed through the Department of Insurance. But we can definitely take this back, because there is a difference between Senator Peterson, to your point, of the business license versus a PBM license. Those are two different licenses that are required for this RFP.
And bidding versus entering into a contract.
Correct.
Yeah.
Specific to the business license, yes. The PBM license, we would need to work with Commissioner Navarro's team and get some additional clarification.
Yeah, to give you an idea, we have about 45 registrants, so it's unlikely that they would be like not registered, and it's also not expensive, so it's not prohibitive to register. So I think that we have an ample sized pool. And again, I just want to caution that we all want competition, but we want the right competition who is capable of handling such a contract.
Yeah, literally. I think Stephanie kind of followed up on the state treasurer's recommendation by incorporating that language, license and register. But I question the timing. Would you want it before the SCBC adopts the recommendation or before the PRC begins?
Let me get back to you on that specifically of when we would request that. Ideally, it would be prior to a proposal being submitted. But let me connect internally with our contract manager to get a specific.
Yeah, my only concern is you go through the process of the PRC and you come out with a recommendation and then you find out they don't meet the standards.
Exactly.
That's my only.
Might be important to have a second and a third, right?
Yeah. Well, you always have a second and a third. But.
Okay, so looks like there's some follow-up needed for item number 10.
Okay. Good to move on to 11. Okay. Next one, and we've had some conversation on this already, but it was around for the commercial contract that the vendor had at least 200,000 members across their full book of business. If you recall, this was a change from the previous version where we had 5 consecutive years of experience. So again, trying to allow more bidders, more new PBMs, smaller PBMs. There was a question from the last SCBC meeting on if that 200,000 threshold would preclude any PBMs. And we went back and took a look at some of the metrics from the emerging PBMs, some more associated with transparency that the state might want to take a look at. Some examples are Capital RX is about 2 million in their book of business. Navitus who is established, is 8.5 million. Rightway PBM is about 400,000. Transcarent about 1.25 million, and Smith RX about 660,000 lives. So this is about double the size of the commercial population right now. So we did see it as allowing most of the vendors that you would at least want to take a look and evaluate to see if they could support a plan like yourself. So open for any comments or questions there.
Mr. Chairman. Again, I just don't understand some of these, like the 10 years that luckily we dropped that down to a more reasonable number. But the 200,000, the 60,000, I mean, that's a lot more than the number that we're insuring. So I don't know why we need those numbers. I mean, 200,000, we only have what, 103,000 or so in our plan. Why are the numbers so inflated?
I think, so I'll just take a stab at that. I think this is across all their books of business.
Yes.
So
Yes.
in some cases, we don't want to be the biggest fish in the pond, right? We want to see that they have a wide customer base that they're providing for. So I'm kind of comfortable with these numbers. There's other things that are kind of where I see it's a little bit more limiting, and I think I'm going to talk about that a little bit in number 13. But those numbers, to me, is across all book of business. And we're not saying one customer has to have 200,000 lives or the like.
Right, but the other side of that is that they could have 100 small plans nowhere near the size of ours, and that cuts both ways. So why wouldn't we just say that they have to service at least one plan comparable in size to ours?
Because in that case, you may actually eliminate a lot of people as well, because the state of Delaware, having 135,000 covered lives, I think they may not have that one big client, but they have a lot of mid-sized clients. Like if we consider ourselves large, and I would defer to Brian as to what our classification would be, but I think it cuts both ways. But these numbers, I don't think are that far out of reach I don't think that's narrowing the funnel as much as some of this other language.
As
So
Brian said, it wouldn't seem to block any of the ones that we would be interested in. So everybody else is comfortable with that. I'll be comfortable.
is that a fair assessment there, Brian?
It is, and I would consider the state to be a large plan. I think some of the considerations, and you kind of mentioned this, but just doubling the number of current lives, we just don't know if the PBM would have the capacity to handle that, like doubling the customer service, doubling the mail order volume, that kind of thing.
And Ed, I'd add too, we've seen some PBMs in the marketplace go out of business or change their focus away from the PBM industry. And so that's a risk element of, we've had some clients that have had to switch PBMs mid-contract because some haven't lasted in business.
Commissioner, did you have something?
Yeah, listen, I appreciate Willis Towers Watson's point there, but to Karen's point, maybe make it a prerequisite, instead of a prerequisite, make it a preferred, so that it doesn't eliminate others who may be capable. Because again, I think that this is in the past, a lot of these RFPs were written with the help and assistance of the PBMs themselves. And so something perhaps we could consider, that it's not a prerequisite, but a preferred aspect of the application.
Okay, so possibly move to maybe the questionnaire portion instead of the min bid requirements.
Well, I think if it's a prereq, it just automatically pushes people out of the system. And so if we change the two, we would prefer that, like we do with other applications within the state. Instead of a prereq, we might have a larger pool to choose from. Just a thought. Like to see what everyone else in the SEBC thinks.
Mr. Chairman, I think that would solve the concern. It's a preference, but not a requirement.
Okay. So is everybody comfortable with this suggestion of possibly the recommendation of moving 11 and 12 more in the questionnaire section of the RFP as opposed to the minimum requirements section? Is there any objections to that?
And 13.
Well, we're gonna talk about 13. I don't know if 13 actually, I want to talk in more detail about that.
Okay.
Everybody
good
good?
news.
I didn't hear any dissension from that particular
You
recommendation.
know, not, Mr. Chairman.
Bill Overly.
You know, I don't know, I'm a little, I guess, uncomfortable in doing that. Although I guess they'll be vetted through the PRC process, but the point is well taken, I think represented by Willis Towers Watson, that some of these very small PBMs may not be as stable in terms of providing the services that they've contracted. So, you know, I'll go with the flow on this one, but I guess I just want to have my 2 cents heard on it. I mean, I'm more comfortable with the current language, but, and believe me, I'm not trying to pull the ladder up. I'm trying to lower the ladder and include as many people as we can in this bidding process. But just a concern of mine.
What's the pleasure of the committee? Do we want to take a vote on keeping these things in, or do we want to have more discussion on it?
No,
So,
I'll defer.
That, you know, in this process, right, it's everything's scored. So, you know, you'll say it's out of a 50 score, each part gets a score. So, you know, if there is somebody who scores higher because of their experience than someone else, that's all considered in the process that goes, it's into this. So I still think that would be fair.
Yeah, I think the one thing to keep in mind is that as you open up some of these parameters, you may be opening us up to a bit of risk. Something to keep in mind. And the only other thing that I would say is that as you open the parameters, you'll also probably see more applicants, which again just means that through that, you know, to Commissioner's point, through the process of evaluation and scoring, they'll end up getting filtered out based upon their outsized risk. So it's just a matter of the volume of applications that you want to review. Do you want to review 45 versus 35? You know, something like that. So that's just my comment.
And I appreciate that comment. I will say that I think that we likely had a limited pool of folks to choose from because of the prereqs.
Mr. Chairman, do you know at 200,000 what we would exclude the PBM? Do we have a knowledge base on that?
Brian, can you address the question is based on the 200,000 members, are there folks that we think we would eliminate as a result of having this particular minimum requirement?
We can take that back and see if we could find specifically which PBMs would be precluded there. I would say they would have to be a very new PBM, like within the last year or two, but we can take that back and see what we could find as far as with the newest of PBMs, their current memberships.
So we do have a takeaway, but I mean, a lot of discussion here. I think the sense is we're a little bit on the fence here as to what the effects of removing this from 11 and 12 as far as, you know, the actual experience of the PBMs. I mean, we're doing a lot here as far as like 3 consecutive years of experience down from like our 5 to whatever 10 we started at. And so, you know, I thought across all book of business, I thought this was kind of like a fair assessment, but I'm hearing others, saying that's not enough, meaning like it should be removed, so.
Well,
Yeah.
Right, if I may, this is Jeff Tashner here. I'm comfortable moving it to the questionnaire because we're not taking it entirely out of the process. And I know our PRC process is, I think, thorough and rigorous from my years of experience. So it's not that we're entirely removing this, as the state treasurer, I think insurance commissioner has said, it places more of a burden on the PRC and a higher reliance on the PRC. But I have no doubt if we move this to the questionnaire, it's something that will be fully vetted and considered. So that's why I'm comfortable removing it from minimum requirements to the questionnaire. That's my understanding what we're talking about. We're not taking it out of the decisional process entirely, which would leave me with angst. It's going to remain. It's just not going to be an automatic exclusion. It's something that folks on the PRC are going to have to take into consideration and will weigh in the scoring, as the insurance commissioner said. So
I can just.
Oh, really?
Yeah, and, I'm not gonna fight this one to the death, but it puts a lot of responsibility on the backs of the PRC. And if you've been on PRCs, there are people who are engaged and there are people who are not engaged in terms of the process. They're not professionals or well schooled in the discipline. You rely heavily on Willis Towers Watson as you go through these PRCs, but the fact that it's in the questionnaire does not mean that you're necessarily going to get the proper outcome. I mean, that's my concern. So
I have one last comment. And that is that we do have professionals from our department on that PRC. And Bill, you're right. It can be 8, 10, 12 hours or longer, several days of discussion. But I can tell you through our experience that they do take it seriously, that they are qualified, perhaps not subject matter experts specific to PBMs, but they do vet these very thoroughly and they're very professional in this process.
Well, Trinity, I certainly wasn't demeaning your office. I just, having, as I said, been involved in several PRCs, not everyone is as tuned in as your office, or as they should be as you go through this process.
Yeah, I don't disagree.
Okay, thank you. I'll defer to the consensus.
So I think, based on what I've heard, unless I hear something differently, is that more of the consensus is that 11 and 12 could move to a questionnaire, stressing that when we do turn this over to the review committees, that maybe we just give them some special instructions to make sure that they pay particular attention to these questions with regards to thresholds of members that they're serving.
Mr. Chair, if you need a motion, I'll make that motion.
I don't think we need an actual vote on that. And this is just, I'm just saying what I've sensed around because we'd have to vote on everything. I just want to make sure I encapsulated what everybody's thinking and take away from the discussion is. Stephanie?
Thank you. Director Hardis, SBO, I would agree. I would recommend to not vote on any of the minimum requirements today, as that full vote to approve the RFP, which includes the minimum requirements, will take place on June 27th. So to avoid any confusion, I would recommend that no votes take place until it is for the full RFP at the next SCBC meeting.
Great. All right, good discussion. Can we move on to number 13, please?
Sure. And number 13 requirement was around the organization having the experience in managing at least 3 large and complex clients similar to the state. This was a modification from the previous, which was asking for 10 large and complex clients with 250 million in spend and 100,000 covered lives. So again, making the attempt to open the pool more here, but open to feedback if there are similar feelings to 11 and 12.
So I'll go first, and I'm sure other committee members will have additional comments. But I guess my thing is, I think this is getting at starting to limit the funnel here, in that we need something similar to the state. So if this language stays at all, because I'm comfortable actually striking it, but if it were to stay in, I would just want it to be that they could provide at least 3 clients that they provide similar scope of services as requested in this RFP, as opposed to similar to the state. And I'd look for my committee members to kind of provide some discussion around that point. Anyone?
I agree.
You're good with that? Yep. So it's going to stay in the requirements, but they're going to give us 3 clients that they're providing similar scope of services as being asked in this RFP. Is that good? Brian, do you have any concerns over that?
No, we can make that update. Yep.
Great, thank you.
Okay, moving to next item, which was number 14. So this was around the account management team. This was also a modification from the previous version. On this one, we're asking for a minimum of 5 years experience for the account executive and manager in the healthcare industry, and minimum of 3 years in our current role. This was a change from 10 years of experience in the industry and 5 in the current role. The idea is here, in working with a plan like the state, having account executive and manager with the adequate industry experience can really kind of change the game in the way the state is served and meeting the requirements. So open to any feedback though. Not sure if you're thinking that the 3 years is going to preclude anyone that you wouldn't want to.
I guess some of the feedback we got was, are we being too specific when we say either working for health insurer or PBM? Could we just be satisfied with healthcare industry, as opposed to going into more specifics? Just a comment that we had received.
Just coming from me, PBM operations are so specific compared to the overall industry. I do think it is a really niche thing. There are a ton of moving parts and to consider there, but definitely open to discussion on this if anyone feels a different way there.
I wasn't uncomfortable at all with this language.
Okay.
I mean, to me, I think it stipulates, it defines what we're looking for in terms of a PBM. And I mean, there's even a state of flux within the PBM community right now. So I think having that experience is very helpful in terms of trying to make a final decision. So.
Okay.
So my 2 cents is, we suggest just the healthcare industry.
So we have a divide.
No, I didn't hear it.
He said his recommendation is that his 2 cents, I think, I don't want to misquote him, but he said he was fine with just healthcare industry. Is that right, Commissioner?
Yes, sir. Thank you, Mr. Chair.
Perhaps demonstrating my ignorance, without specifying PBM, can you define for me the difference between at least your understanding of a healthcare industry and a PBM, which is part of the healthcare industry?
Well, it's the same premise, and that is that we don't want to limit the pool. If you have that experience, and I'll say that I think we want to ensure that they have one of those years as forgive me for the acronym, it's a PSOA or AO aggregator. that's very similar to a PBM that can do the same work. Again, I appreciate that we want to have folks here who understand what they're doing, who have the experience. But what I'm trying to do, I think it's pretty clear, is to open up that pool.
So we'll have further discussion about item number 14. If we could go on to 15.
Sure. Number 15 was around the pass-through of rebates, and we made every attempt to make the definition include any revenue that was passed on to the pharma manufacturer. So kind of had a all-encompassing definition there, and that any kind of revenues would be passed through to the state. Any concerns on that one or questions?
Mr. Chairman.
Yeah, we got some questions.
Yeah.
Karen Peterson.
Yeah, is this the same language that was in the 2020 RFP? Because it seems that there are lots of other kinds of money flowing to the PBM that the state never sees. So is this different language?
I have to go back and take that as a takeaway to compare the exact two. I believe that we did update certain portions of it, but I have to go back and directly compare.
Okay, because if this is the same as before, there are a lot of things that the state's not getting. So I don't want to think that we're getting 100% when we're getting 100% of what we know about, but 0% of what we don't know about.
Overly, you had something on that one? Well,
And again, I may be showing my naivete, but in the current environment, it seems to me that my perception is there's a complete lack of transparency. And it's very difficult to define, the extent of the rebates and what the state is getting back. And when I got into this at the outset, we talked about a cost plus model. And in my mind, and again, maybe it's my naivete, cost plus to me is the basic cost of a generic and name brand drug, plus an administrative fee to administer the program and to pay the pharmacy to fill the prescription. And that's not what I see here. Again, I tend personally to oversimplify complex problems. That can get me in trouble, or it can also in something very positive. But I just don't see that process laid out here. I don't know.
Yeah, Mr. Chairman, I would just add to both comments. I think, the rebate is just one of many ways of a PBM to acquire revenue. And if you just focus on a rebate, and I agree with you, I think you have to really audit that to verify that we are getting the rebate. But there are other ways. So for instance, the administrative fee. So many times the manufacturer will pay a PBM to manage a rebate a certain way. This has no requirement over that. We need to know that. What is the PBM's contract with a local pharmacy? And we need to know that. Now, maybe this is not the right place to put this. I don't know. This is the first time I've ever seen this. I don't know whether you in 25 you deal with that issue or not. I have no idea. But I mean, there are other hidden costs that I think at the very minimum, we have to state that we want to see this. We want full disclosure. That's just my opinion that I think you should put into this agreement.
We did. Oh, go ahead.
I think our comments for item 15 were pretty expansive. Manufacturers not sufficiently exclusive. There are many other non-manufacturing fees that we should have access to. So I don't want to take up too much time, but it's in the comments as well.
Okay. We did try to address the manufacturer administration fees in this one. If there's additional that we need to put in, we could definitely take that back, but we did try to capture that here. And those are being passed through today by CVS, the manufacturer administrative fees at 100%. Also, we're trying through the audits to capture what exactly is being passed on from the aggregator or from the pharma manufacturer to the PBM and uncover it that way. But this was just as far as a rebate definition. There were comments about the acquisition cost pricing models too, and we are asking for a acquisition cost pricing model in the bids. But even those models today, the way they're currently set up for branded medications, they also have rebates attached to them. So we're not away from that. Just the marketplace currently isn't away from the rebate model. Maybe it will someday, but even those acquisition cost pricing models that are emerging do have rebates attached to them also for branded medications.
Sure.
Mr. Patrick.
I apologize because I stepped out and this may have been addressed. The concern I have with the definition of rebate, it doesn't tell me what the rebate is off of. You know, is it the cost I set? Is it an average cost? Is it a list price? Is it the NADAC? I mean, we've heard a number of different costs throughout the last month as we've talked about this. This is just telling me a rebate, a discount, or other price concession that's based on utilization and who it's paid by or how it's paid, but it doesn't tell me where it's coming from. And I think that's incredibly important because over the years, you know, we've heard about bending cost curves and doing stuff like this in this whole area. My angst has always been if the prices are just, by terms, simply too high, I really don't care what rebate you give me because the rebate's bringing it down a little, but I'm still paying a price that's simply too high. So I need something in here personally that tells me what's the foundation? What's the baseline that we're saying that these rebates are off? And everything I've been reading in the last month says that that's kind of the game that's played in this industry is they promise you rebates, but the rebates really aren't getting you to where the price should be at the end of the day. And I think for all of us, the state in particular, which pays 90% of this plan, we should want to get the costs down. So that's my problem with the minimum requirement as it's currently stated.
Laura, yeah, and I guess reiterating some of what Jeff said, I guess my hope is that we get to a place where we can look at the net cost of the drug, the actual cost after the discounts and rebates. You know, I'm not sure how you get there, but you know, it just, to me, there's too much wiggle room left for these PBMs to juggle the rebates when you actually can't get to a bottom line. What is the actual cost of the drug plus the administrative cost to provide service to the state of Delaware? Now, how do you get from A to B? I'm not quite sure. I don't think the language of 15 does that.
I do want to let everyone know that Lieutenant Governor Kyle Gay and Stephen Constantino have joined the meeting.
Thank you. So I guess to Brian, like a lot of this angst around 15 is about transparency. And so what is it we can do to satisfy some more of our desire to get more transparency around the topic of rebates? So if you could kind of do some research and get back to us as to how we could possibly enhance that, that would be great.
Sharon,
Karen.
to follow up on what Bill said, I like Bill, I would like to see us move to simplify this whole process. You know, the old saying that a camel's a horse designed by a committee. That's what this reminds me of. why can't we have a simplified version? Tell us what the net cost is, okay? Add an administrative fee to that, a flat fee, not a percentage, and there you have it. Why can't we get to that in this process? We just make it so convoluted and confusing, and you got these things behind the curtain that we don't know about, and I requested that printout of what are you getting? The PBM, what are you getting that we're not getting? And they wouldn't break it down for me, but they gave me a list of lots of money. We have no idea what that is or where it's coming from. And I just don't want to repeat that here. I would rather we head in a whole different direction where we can actually understand what we're getting and what we're paying for. But I'm not sure how we get to that. And because if I were a bidder and I saw this packet, I said, you know what? I'm out of here. Well, you make this so darn confusing, questions on here, what if somebody gets sick? Who are you gonna put in their place, all the rest? They're ridiculous kinds of, it's just, I don't know. It's way over the top, but my opinion.
Mr. Chair, one more comment.
Yeah, Commissioner.
So I have to jump on to something else. We'll try to get back on, but Chris Haas has, she's on the call and she's with the department and she's really the smartest person in the DOI besides Tanisha. But to Senator Peterson's point, and I'm not suggesting that this is definitely happening, but I suspect that it is, that rebates can be changed. They can be manipulated to change the formularies. And again, I'm not saying with certainty that that's what happened with Zepbound, but I'm suspicious. And so if there was a way to simplify this, because this has been a way that PBMs have been able to manipulate things that is really unfair, specifically for entities like the state of Delaware. So with that, I yield my time to Chris Haas. Moving forward.
Thank you. Steve, you have your hand raised?
Yeah, thank you. I think the most important thing here in rebates, and we've seen this in the Medicaid program over the years, where MCOs have to pass the rebates back to the state. That's the most important thing. I don't like the word confirm because it seems passive in a way. It's like, I think that we have to actually mandate. We have to use a stronger word there. We have to mandate that 100% of the rebates will pass to the state or whatever we're trying to accompany. I think the wording is just too soft. It's almost like a checklist. Oh, we checked it, we can confirm it, but we're not really proving that they actually do that. I think that's an important piece that we should probably flesh out a little more. Remember that rebates are only on brand drugs, right? And the other thing I think we have to check, whatever we're squeezing here from the potential bidder, we got to make sure they're not finding another area where they make it up, right? You squeeze the balloon here, it's gonna find somewhere else. So we need some really down deep analysis to make sure they're not doing that and finding the money another way. I think that's important. But getting 100% of the rebates is critical here because that's what our goal should be.
Thanks, Steve. Bill Overly?
Just a kind of visceral response to that. If you give us a good price at the outset, there's no need for rebates. I think the point that at least three of us, or perhaps four around this table, are trying to make. A true cost plus scenario. Simplify the process. I know we've strengthened the auditing, proposed audits moving forward. I mean, if you had a model like I'm suggesting, you could save money even on the audits if you knew exactly what you were paying for, without having to delve in to make sure they're giving you the rebates that you're entitled to.
Mr. Chairman, okay. I just couldn't agree more with everything that's being said. And, I think we're at a point where None of us have an answer to this, okay? I offered, but you rejected, to have Vincent at least try to provide additional insight.
I think we made a request of you and you didn't get it in a timely manner, so I wouldn't say we denied it. We made a request.
The email I got back was, we don't think that would work because we have to move on. I will be more than glad to go back to them, to provide, or if we have questions, just to get some kind of additional insight on how other people are dealing with these questions. It may be worth it, it may not be, I don't know.
Yeah,
I mean,
I'm not trying to paint that there's this unicorn that we're gonna find out into the forest, right? You know,
where we are.
we are a pretty sizable client, but also there's a market out there, right? And the practices of the market revolve around rebates. I'm not saying good, bad, or indifferent, like it, don't like it, but like some of this, you know, we can't change because that's the market and that's how it works. We can push back on the market, but are we gonna, or is it gonna win, right? And we might get something else that's not as good as what we had before. We don't know what's gonna come out of this process, right? I totally am open. I'm trying to hold an open process here and we're trying to get, but adding another person into the process at this point in time, like we're never gonna get this RFP out
Right.
in the time frame
I'm not
that we
saying
have.
that we're adding, I'm just saying that there'd be another person to inquire, what are you doing about this issue?
I would love to hear from my committee members as to how much they can internalize the material that they had before, because I'm struggling with it and I feel like I'm pretty good at handling a lot of different information sources.
Right.
It's overwhelming.
Well, I think sometimes when you get a company that's been dealing with this for quite a long time, maybe they would have additional insight that we don't have. I don't know, just a question.
Do you have any further comment? All right,
So what are we going to do with 15?
15, I've directed Willis Towers Watson to kind of look back and see if there's something we can add in here in an effort to get more transparency on, you know, the fees that were being charged and things that are not being passed through to us 100%. Yeah.
Can we just look at or talk about switching the whole model to a cost of less drugs and not go through all this rigmarole?
I think that talks about that in number 16. Am I right, Brian?
Yeah, that's correct. And I wanted to. Oh, sorry.
It mentions it, but was that in the earlier RFP too? Because if so, we just got skimmed right on over. Nobody paid a bit of attention to it.
Director Harvest, I can speak to this. Yes, this was included in the earlier version of this RFP as well as in the 2020 RFP.
So it was meaningless.
We did not receive any bids in 2020 on a cost plus model.
Yeah.
It was included though.
But if we had made that, because what we're saying here, and we say it at the very beginning of this document, it says, we want to duplicate our current plan. Well, maybe we don't want to duplicate our current plan. That's what it says on page 5. That's what we're bidding. That's what we want you to bid on. Duplicate the current plan. And what we're saying is maybe let's not.
Stephanie, you just said that this was in, have we changed the language for 16? Because this says confirm that you will provide an acquisition cost plus proposal. And I guess if this is a minimum requirement, my curiosity is if no one provided us with this, how did they meet the minimum requirements?
Good point.
I'm comparing currently to the 2020 RFP.
Yeah.
I do not see any changes in the language, but let me take that back.
Yeah, because I mean, it just, you know, I was comfortable, I know I'm jumping ahead. I was comfortable with 16 because it's not, hey, think about it. You will give us a cost, you know, a cost acquisition, cost plus pricing proposal. So even if that's not the one we accept, the way I read this, in order to be a viable bidder, you have to provide that proposal.
Yeah.
So.
And Mr. Chairman, can we change that to net cost? Insert net.
So for the acquisition cost pricing models, and I think this may get you what you're looking for. We would have the acquisition costs than any type of markup, any type of dispensing fee. But as I mentioned before, just the current state of the market is that rebates are attached to brand name medications. I'm not aware of PBMs that don't receive a rebate from pharma when they dispense a branded medication, but it would all be transparent to you. So we're soliciting bids from PBMs that do specialize in these acquisition cost models that would be more transparent, where you would see it all laid out for you. So that is what we were trying to accomplish by soliciting acquisition cost bids in the RFP.
Steve?
Yeah, Brian, quick question. Aren't most of the cost plus situations dealing with generics and not brands?
No, it's brands and generics.
It is brands?
Yes.
Okay, I just wanted to clear because
Yep.
I thought like even the Mark Cuban program
So
is very limited. They're adding brands very slowly, but
that's correct. Mark Cuban, which is not really a PBM, but
Right.
their service specializes in generics and has limited brands.
Okay.
But these PBMs, say just for an example, like a Capital RX, it would be for all medications.
well, that's good to hear. I'm glad.
Yeah.
Thank you.
Sure.
Did we satisfy, Karen, did you get satisfied as far as like the net, like adding net as opposed to?
Yeah, well, I think even more important is Jeff's point about they're required to submit this with their bids, but apparently that wasn't done in the last. I mean, that makes me happy. Bill? If they're required to submit a cost plus bid as well?
Yeah, I'm.
Bill Overland.
No, I'm sorry, Mr. Chairman. I'm just struggling with the whole rebate environment. I guess what I'm hearing is that most PBMs operate in a rebate environment. Would this language require them to disclose and factor in the rebate in the net pricing?
It may vary from PBM to PBM, but from what I understand, yes, they would disclose the rebate amount. So you could see the total net cost of the prescription.
Thank you.
So 16 and 17 were around the types of bids that we were asking for. So as we discussed, 16 was around the acquisition cost or cost plus pricing model, and 17 was around a similar pricing model that you have in place today, which is based on AWP pricing. Were there any other comments on that portion? For number 18 was around audit rights, and this is where we were making an attempt to get to that transparency, just kind of naming any kind of agreement between the PBM and pharma and anything that contributes to the pricing of a medication. So not sure if there were any comments or concerns with that definition in 18.
So from the Department of Insurance, I think our recommendations for 15 could sufficiently solve for this, but we also wanted to offer consideration of, again, making sure we're not just limiting ourselves to pharmaceutical manufacturers, but also, wholesalers, distributors, the aggregator contracts. And so perhaps removing the word pharmaceutical from ability to review contracts would help us ensure that if an aggregator is, for example, retaining rebates on behalf of the PBM instead of those getting passed to us, we have some line of sight into that.
Thank you. And I know we were going through those recommendations and looking to incorporate them. Okay. If no more comments on 18, I'll move to 19, which was around confirming that the organizations own, and this gets back to the last comment, that they own their own rebate contracts directly with a pharma manufacturer. And if they don't, if they do use an aggregator, that those contracts will be fully auditable. There was some concern here that maybe the smaller PBMs wouldn't have access to, or wouldn't be able to provide access to those contracts between the pharma manufacturer and the rebate aggregator, and possibly moving this to the questionnaire. But for now, we have it in the min bid requirements. Any comments or concerns with that one?
Just would this, to your point, if this is a minimum requirement, would that prevent the smaller PBMs from entering?
Kristen, you might be able to weigh on this.
Mhm.
Yeah.
It could. With the smaller PBMs, they all tend to use the larger GPOs or the aggregators.
What I thought.
So they don't tend to have their own contracts. We've seen a variety of arrangements there where some can offer the full auditability of the actual contracts and some cannot. So this could preclude some of the smaller PBMs.
Yeah, I would be concerned about that because I think we want to get the full breadth of both the small and the larger ones. And I think if this limits that, we'll be moving in the direction where we're not seeing these boutique PBMs in the solicitation. So that would be my suggestion, to kind of rephrase this in a way that opens it up to them.
The Department of Insurance would agree with that.
Any additional comments on 19? Okay. All right, moving to number 20, and this gets back at the transparency more that we're looking for, is just confirming that your organization will provide reporting on the acquisition costs of all claims dispensed under the plan, even if the state did not implement an acquisition cost arrangement. Any concerns there?
Not a concern. I'm not sure I completely understand the language.
So basically asking for the PBM's acquisition cost, even if, so say you stayed with your current arrangement, which is an AW minus pricing arrangement, even if you stayed with that current arrangement that you had in place today, your current pricing model, that you could request reporting on the acquisition cost of medications. So not moving.
Simply a default.
Yeah.
Okay.
Okay. Next one, number 21, is around rebate guarantee modification. So this is kind of a standard in PBM contracts. If there's some kind of market event, or if you put in a clinical program that is going to modify your utilization, that the PBM kind of has the right to go back to those rebate guarantees and make adjustments. And this one was just stipulating that the PBM could not open up the contract unless there was a 10% or greater loss in total rebates, and supported by documentation there. We had some consideration to move this to the questionnaire. Just with the current pricing models, there's maybe not as much of a focus on the rebate guarantees as previous years, but just wanted to leave it here and open it up for any discussion.
Any discussion? Keep moving.
Okay. Next one, number 22, was around the state having the ability to audit all aspects of the plan. So again, getting it transparency, again, getting it where getting into the rebates more and being able to open up the contracts, just any type of aspect related to pricing, having the right to audit those components of the PBM for up to 3 years following the termination of the agreement. So just try to get an all-encompassing definition there, but if there are suggestions to add to that, definitely open to hearing that, but wanted to open that for discussion too. Okay. If none, I'll move to the next one, which was, and we did discuss this previously, but this was around the organization being willing to provide NDC 9 level rebate reporting in accordance with the definition of rebates in min-bid requirement number 15. So there were some questions before about the difference between NDC 9 and NDC 11 level reporting. And what we were going to suggest here is to leave this NDC 9 reporting requirement as is, and also add into the questionnaire a request around NDC 11 level reporting. So NDC 9 leaves off the package size of the product. NDC 11 includes it. So with NDC 9 level reporting, you have the medication and the medication strength, the manufacturer, but the package sizes are rolled up. So you might not get the exact rebate of the claim, but as we understand it, this is where a good portion of the market is at right now. It's not standard to provide NDC 11 reporting, but we still want to ask for it and have that be evaluated and considered when scoring, but leave the NDC 9 level in the min-bid requirement. Any questions on that one or any comments? Okay. Next one is around the vendor's experience in providing PBM services for large municipalities and state governments. So just around their previous experience, it's kind of I would say a little bit of a loose definition, but just confirming what experience they have.
So Brian, to this one, I think I satisfied it in number 13 when we talked about it. So
yeah.
I would like to get some guidance from the committee whether they're comfortable removing 24. Because you would think if they were going to provide in 13 customers that they currently provide the similar scope of services, that they would provide either a municipality or like services of other companies in the private sectors. Everybody comfortable with that? Any objections? I don't see any, so I think we can strike 24.
Okay. Okay. And the last three remaining are just standard GSS requirements. So not sure if any of these were up for any kind of conversation, but these are just standard. I'm sorry, also 28, I missed that one. So any more questions or comments on the minimum bid requirements before we move on?
I think Bill Oberly has a comment, and then Joe Tashner.
Yeah, just one more, and I throw this out for consideration for inclusion in the RFP, and this comes from a suggestion from someone much smarter than me, but if you want to actually drill down to the net cost, why not include in the RFP a list of 100 drugs the state currently, the recipients are currently using, both generic and name brand, and provide the prospective vendors with the opportunity to provide the net cost of that drug that they would supply to the state level.
Okay, so just request either in the min bid requirements or the questionnaire that the bidders supply, we provide a list of the top 100 drugs, and the vendors would provide the acquisition cost and net cost, including rebates, currently for their organization.
I think you,
Then we would have an opportunity to compare apples to apples.
is it, may I ask a clarification on that? Are we talking about the top 100 drugs in terms of utilization or the top 100 drugs in terms of cost? Two different.
Utilization.
Okay, just make that clarification.
So most commonly dispensed.
Could we split the baby as far as utilization and then most expensive, or is that getting into specialty where you're starting to get into the carve out?
It's a good question.
Like I'm just trying to think, even there's two components here, right? Utilization, if utilization, you could be getting a really good price on something that they deal a lot in, so they can offer you a really good price, right? But then you got the other part where we're paying a lot for some of these.
Once we looked at it, the top 100 cost to the plan based on price and utilization that we currently have.
Yeah,
right?
That would, I think.
Yep.
What costs us the most money currently, the top 100, and that's driven by price, utilization, or the combination of both. So that's how I would do it.
Yeah.
Is that doable, Brian? You think that's a reasonable request? I think it would be a good
That's what you want.
sample. Yeah.
Yeah, we can ask for it. I haven't seen it done in other RFPs, but I agree it would give insight into what you're paying today and what the acquisition costs are and the net cost. So.
And then Brian, my general question for you, I'm just trying to get a sense and process check, I guess, myself and maybe others. What's your sense on how all this does or does not expand the pool of eligible PBMs? I mean, back in 2020, I don't know how many people were eligible. And where do you think this puts us? Have we truly accomplished our goal of opening up more broadly this RFP?
In my opinion, you have. It's such a difference from the last RFP, and I don't see that you would have vendors that you want to evaluate that would be emerging and providing these new pricing models. I don't believe you'll be leaving them out, any that you would have any confidence in them supporting your plan. So I'm confident that this is opening things up, my opinion.
Thank you.
Sure.
Is there, we got through the minimum requirements. What was next, Stephanie, that you would like feedback from the committee that help us achieve our basket plans?
I believe the request is to review comparisons from Senate Substitute 1 for Senate Joint Resolution 7 to the RFP.
All right, so I would ask, in light of time, because we've been at it for an hour and a half, and I know we have other things on the agenda. That document was provided to everybody. They can review it, have questions or concerns, the information, and we can, you can communicate to SBO and the chair and vice chair if there's concerns, but I think that's something we could all review in our own time, if you haven't done so already.
Mr. Chairman, I would also just add, the last slide on that slide deck is also included in the RFP, does have the draft scoring and weight criteria. I would highly recommend that the FTBC prioritize reviewing that scoring and weighting criteria, as it really is for the PRC, the decision-making factor on the award recommendation.
So I wouldn't mind touching on that for a little bit, just to make sure, we're not too far off of what we're, evaluating and make sure we have, pretty strong consensus, if not like minor tweaks that we would want to make. So it's slide 12 of that slide deck. And I know we all can read, but responsiveness, we're giving a 5% weight to that, cost 40%, network and formulary 15%, administrative services 5%, audit rights, transparency, and flexibility 15%, and then ability and capacity to provide requested services 20%. Stephanie, if I could ask, how different is this than what we did in 2020?
Yes, so there are some changes to the weight for 2020. I can send a direct comparison. I believe it was in last month's slide deck from the previous to the current scoring criteria. There were some additions related to audit rights and general capabilities to provide the requested services. Most notably, in the 2020 RFP, cost had a 50% weight. And as the addition of these additional requirements and interest from the committee related to transparency and audit rights, in order to account for those additional asks, the cost component was dropped from 50 to 40%. Though again, happy to send a direct side-by-side comparison from the prior to the current scoring criteria.
Steve, you have your hand up?
Yeah, I'm, again, what the lens of looking at this to wanting to increase participation, the ability and capacity to provide requested services, prior experience in providing scope of services, managing clients of similar size and complexity to the state. I think we're inadvertently just limiting this to certain PBMs. And I think if we could look at that language and trying to make it kind of opening for the small, like I said, the boutique PBMs, I think that will reach, I think you'll get some boutiques who will not qualify. I know this is they may apply, but if we're gonna, in the back end, kind of extinguish their potential.
I think this is a matter of catching up to our discussions that we've had, today.
Okay.
And so I think that language needs to be massaged, because we talked a lot about, moving things to the questionnaire as far as the, book of business. And then I also, kind of eliminated some of the language around similar in size to the state. And we talked about
Okay, great.
providing, clients that you provide similar scope of services. So I think this is just a matter of us catching up to that.
Okay.
I am comfortable that weighing it at 20%, because I think it's important that they have we judge it on the ability and capacity to perform these services.
Thank you. Yeah, that I didn't realize we're kind of catching up on it, but that's the one that just screamed out at me a bit.
Yeah, I think this is just a matter of catching up with the edits that we've done earlier today.
Thank you.
Mr. Chairman, I can just confirm now, audit rights, transparency, and flexibility is a new topic and weight for this RFP. Cost was decreased from 50 to 40%, and administrative services was decreased from 10 to 5% to account for that new 15% weight for audit services.
And I think that reflects the sentiments of the committee in trying to get more at the transparency component of this service. Everybody in agreement? No?
Yeah.
Tasker wants to wrestle.
No, I don't want to wrestle. I want to think about it. Because my reluctance is to drop price, right? And I understand why we're doing what we're doing. I look at administrative services and ability and capacity, and I understand what they are. they're going from 25 to 30, which is fine. We added the audit. I think everything needs to be there. I'm still just thinking the mix. And when Stephanie was talking, I was writing the numbers down off the old one to try to think. So I respectfully ask for a little more time to think about this outside the meeting.
Absolutely. I just didn't want us to be like,
No, I
I
think
think we're that far apart,
I
because
think it's great that you called it out, and I think what everybody's got to think about is, are we comfortable dropping costs essentially by 20% from 50 to 40? Or do we want to see if there's a way to maintain some of the costs and maybe modify some of the others? And I know we audit rights, transparency, flexibility. I want to go back and look at some of the others and see where the overlap is there. We came in at 15, which might seem good. Maybe we could go 10. I don't know. I just want to think about it. Right. Got it.
From the Department of
wrestle, I wanna
Insurance. Well, we think that the shift in weighting is appropriate because our team and the review committee will be taking into account cost on other factors. For example, if your formulary has a poor score, that surely is going to impact your cost. But we wouldn't feel comfortable awarding, full cost points to someone that has a poor formulary, and that's why they're meeting cost standards, if that makes sense. So I think while it's, still a significant percentage, it's also theoretically built into the reviews of the other components.
That's helpful to hear. Take that into
Yeah.
consideration.
I also think we have to be cognizant of timing of everything. So coming to a consensus would be, I think, beneficial overall.
Mr. Tasher's requested more time, but he's assured me that he doesn't think we're that far off as to what's been presented today. Is that a fair assessment?
That is correct.
Okay.
I'm not ready to consent today, but we're not. Just want a little more time to contemplate it.
He wants to dance, not wrestle. He's dancing right now.
Fair assessment.
All right. I think does anybody have any final comments with regards to agenda item number 4? Okay. We are going to go to agenda item number 5, which pertains to an executive session pursuant to Delaware Code, Title 29, Chapter, it's like, what is it, 104B? No, if I misquoted it, it's on the screen here. But we are going to go into executive session, then we will come back into open session for public comment and other business, and eventually adjourn.
Need a motion to.
No, I'll entertain a motion to go into executive session.
So moved.
Second.
Second.
All right. All those in favor say aye.
Aye.
Opposed? None. All right. Thank you. All right. It is 12:55. I'd like to call back to order the SCBC committee. We're going to pick back up at agenda item number 6, public comment. So I'll turn it over to HR.
I'm going to share my screen. I'll take it over from Brian.
Before, Mr.
Yes.
I had just one question. We have one more meeting scheduled in June. It's a good thing. We will approve the final RFP.
That's the expectation.
We have a lot of balls up in the air right now. So I just wanted to raise the question. It can't build a consensus at the next meeting on the RFP. I assume we'd be meeting shortly thereafter.
I will not be meeting shortly after July because it will not be in the state I actually will be out of the office. So unfortunately, without me in person, based on code, we can't actually have a meeting. So unfortunately, that's not by design. It's just like, that's why I kind of wanted to have this meeting. So if there's something that really thinks we're going to have a problem coming to consensus on, ask you to direct that to the SBO, and then, we'll try to wrangle it.
Well, I was looking at the timeline for the RFP and then the PRC and then final recommendation, the SCDC, which I believe is in December or something.
Right.
I'm the last half empty guy, so I always anticipate there may be problems.
I'm being very optimistic.
Okay, we'll balance each other out.
Yep.
Okay, I just, to play devil's advocate.
People.
Ready? Yep, so we did have one person pre-register for public comment, that would be Stephen LePage. See him there, so whenever you're ready.
All right, thank you. I just want to focus on what the priority should be for the state. So in your scoring criteria, you should provide, I believe, more weight to net cost. Net cost is going to give you everything. But net cost, most importantly, is going to hit you in your budget. So focusing on rebates is fine. That's part of the picture, but it's not everything. You really want to get down to the bottom line, you need to go to the net cost. So for example, let's say you have drug A. Drug A is $1,000. Okay, they're giving you a rebate of $400. So that's a net cost of $600. But then they've got another drug similar to it, maybe it's a generic, and it's $600. And you get a rebate of $50, which is lower than the $400. But because you're focusing on the rebates, you're seeing that $400 and your eyes just light up. And they're only giving you $50 for the second drug. But your net cost is $550. So it's still lower. So if you have like drug A, $1,000 cost, they give you a $400 rebate, your net cost is $600. Drug B, $600 for the drug, a $50 rebate, your net cost is $550, $50 less than what you would normally pay. So focusing on net cost, I think, is an important issue, and that should be part of the scoring criteria. The other issue is in the scoring criteria, when you're talking about formulary, I think another important part of that is who controls the formulary. So for instance, we've had a number of comments about Zepbound, right? So CVS removed it. So why did they remove it? Is it removed so that people can get the higher cost medications? It's going to cost the state more. So these are questions that you got to ask. So who's controlling the formulary? It should be the state. And those people that are on Zepbound now, they shouldn't have to come off of it. They should be grandfathered into it if they're going to make a change like that. So that's my comment. Thank you.
Thank you. Is there anyone did? Okay. Yeah. All right, next up we have Mary Grant, whenever you're ready.
Thank you very much. Chair Maxwell and the rest of the committee members. My name is Mary Graham, and I've been watching the SCDC for a couple of years now. And I also participated in the audit PRC as Karen Peterson's designee. And a couple of things that I want to say. One is I'm really happy to see this committee moving to try to get out of the mire of the existing PBM world and contract and look at something very different. And I do think looking in the health industry, don't restrict yourselves to the PBM industry because right away you may be eliminating some things. I had just noticed on the break under your waiting card where it talks about network and formulary. It says convenient retail pharmacy network, including an IDA supply retail network and formulary, blah, blah. If these folks have to have their own network and formulary, I don't know. I mean, it seems a little odd, like is CVS going to allow its pharmacies, to give somebody else a benefit? I was wondering about that. The other thing is, and Brian Halloran, I don't know if he's still on, but he had asked, he was talking about how to the wording in connection with rebates and making things more transparent. And he was making had picked up on a good point that everybody had been making. And at a very specific level, I just wanted to make sure, I think the wording should include a requirement specifically. The current CVS contract under 7.4 says the state does not get certain things. You get the rebates, but you don't get purchase discounts, so volume discounts, or prompt pay discounts. So CVS, if they're listening and they're sitting there, yeah, we're going to focus on rebates because we'll just make these other things be higher that we profit from. And we cannot audit those. The audit contract with CVS, with the current auditor specifically said, you could not audit these other things, only rebates. So I think it's really important that while you're trying to be transparent, you exactly name what it is that the current contract says you don't get, or you know how things work, you'll get down the road and everybody's busy and they're not thinking about it, and they'll sneak right back in that you don't get prompt pay discounts or volume discounts. And I don't know why you wouldn't get a pro rata portion. I mean, it just makes sense, right? You're part of what contributes to their making money from a prompt pay discount and a volume discount. Why wouldn't you get a portion of that back? So thank you.
Thank you. Is there anyone else logged in virtually? Please raise your hand. You can hit *5 if you'd like to make a comment. I think that's everybody for today. Oh, I will turn it back over to Director Maxwell.
All right. Then item number 7, any other business to come before the committee today? I'll just reiterate, the concern that we won't be able to come to consensus. If there's a topic that you think will be very challenging to come to consensus on, the earlier we're made aware of it, the earlier we can kind of try to take action and try to get clarification on it.
Mr. Chair, the very good work that the consultant for the insurance department did, will those suggestions be incorporated into the final draft?
I think we're, some of those I brought up today, but I think we're supplying them, they have the document and just haven't had a time to fully vet those, but I think we should definitely, make sure that some of those tweaks do get made in there.
Okay.
I mean, some of the things, that were suggested weren't 100%, affirmed by committee members. And particularly the talk about healthcare industry versus Bill overly specifically said, I kind of like having the PBM because that experience I feel is important. And that's what we're really looking for. And so we'll try to make sure we're paying close attention to the incorporation of those things.
Just one other question, I guess. Our next meeting is the 23rd or the 30th?
27.
The next meeting is Friday, June 27th from 2 to 4.
I'm wrong. Okay. The final or the draft work product, based on the input we've given today, when would you anticipate that would get in our hands?
So that will be shared by end of day, June 20th, 1 week prior. And that is actually specific to changes recently effective January 1st of Delaware Code that requires, prior to a vote on a health-related RFP, the Statewide Benefits Office share the full draft RFP with the agenda, which is required to be posted 7 days in advance. So to that note, if there is any additional committee member comment or feedback, I would request it by noon on Tuesday, June 17th at the latest, to ensure we can incorporate any feedback, circulate for all reviews, including with the Department of Justice, prior to posting publicly on Friday, June 20th.
Thank you.
Mr. Jackson.
And if I may, probably along the lines of that, I'm still thinking about the wrestling, dancing, all that stuff. And Stephanie, I offer this up for you and your team to work on with Willis Towers Watson and others. I guess, and I hear what the Department of Insurance said about the 40%, and what I'm going to throw out is I could probably live with the 40% if I felt that the scoring criteria that we had last time was changed this time to be more focused on net cost, right? Because when I look at it, the way it's worded, it talks about competitive discounts, rebate guarantees, administrative fees, and maybe we've gotten headed in that direction. To me, 40% heavily based on net cost is probably more valuable than 50% based on what it was. So I just offer that for your consideration, and maybe that allows us to work in as I'm trying to figure out whether I want to wrestle, dance, or whatever it is Brian has invited me to do. So does that help?
Absolutely. We will definitely take that back. Thank you.
Yeah, so what, the one comment I'll make is, the talk about getting our 100 drugs on an exhibit and getting that information, I think that is going to kind of direct the committee to look at that as far as their scoring around cost. So it's going to put a spotlight on it. So, like I said, as you continue to.
As I would agree, I promised you I'd think about it, and I'm sitting here thinking about it, and what dawned on me is it's not just the number that is important in the weighting, but it's what you're actually weighting.
Right.
And when I went back and looked at the documents, it was still heavy on discounts, rebates. I'm more comfortable if somebody brings something back. I'm closer to consensus if somebody brings something back, even at the 40%, if the focus is more on net cost, if that helps.
And may I just, Stephanie or Pay by Benefits Office, may I just add one suggestion related to that net cost? As we were talking about the top 100 drugs based on either utilization or pricing, if you're looking at top 100 based on utilization, you're mostly going to get all non-specialty. But if you look at top 100 based on pricing, you're mostly going to get all specialty. So could I propose that we request top 50 non-specialty and top 50 specialty to ensure review of the.
Whatever you're comfortable with. I offered that, we talked about that earlier. We talked about utilization and price.
Right.
Together, they drive the cost that the plant pays. So that was one alternative. If you think we're going to get better information, whichever one gets us what we're looking for, personally, I'm comfortable with. I understood Brian's point about price and utilization.
Yeah.
I was trying to help him out.
We all good?
Yeah, absolutely.
All right, I'll entertain a motion to adjourn, even though we don't need it, but.
Second.
Second, Stephen.
All right, thank you so much. Enjoy your weekend.
Take care, everyone.